Good morning, good afternoon, and good evening to all of you around the world. Welcome to this satellite session organized by the Sequin network, part of ICAP at Columbia University. This session will be on leveraging differentiated service delivery to enhance coverage and completion of TB preventive treatment. My name is Greet van der Briel. I am a regional clinical advisor for ICAP based in Burundi, and I will be co-moderating this session with Lynette Mabote from the Treatment Action Group in South Africa. So during this session, we will be hearing from 5 speakers. We will start off by Dr. Andrea Howard, who's the director of the Clinical and Training Unit at ICAP in New York, and she will speak on scaling up tuberculosis preventive treatment for people living with HIV, a global imperative. Then we will hear from Dr. Vindi Singh from WHO on the WHO guidelines for TPT for people living with HIV. This will then be followed by a talk from Dr. Teep Al-Samarai. She's from CDC and the Office of the Global AIDS Coordinator, and she will talk on adapting the PEPFAR TPT guidelines in response to COVID-19. Then we will be hearing from 2 country experiences. The first will be from Uganda by Dr. Proskovia Namwenge, and she will be speaking on leveraging DSD models to expand tuberculosis preventive treatment coverage. And the second one will be by Dr. Chlorata Gwanzura from the Ministry of Health in Zimbabwe, and she will speak on feasibility and acceptability of providing TPT through community ART refill groups. We will finish off the session by questions and answers. So if you have any questions, please type them in the chat box for us to see them. So we can go now to the 5 speakers. Thank you.
Hello. I'd like to thank the organizers for inviting me to speak with you today about scaling up TB preventive treatment for people living with HIV, a global imperative. And I have no conflicts of interest. It's my pleasure to kick off the agenda today. As you see, I will be joined by colleagues from WHO, PEPFAR, and the Ministries of Health in Uganda and Zimbabwe for what promises to be an exciting discussion about leveraging differentiated service delivery to enhance coverage and completion of TB preventive treatment. As you know, TB remains the leading cause of death among persons living with HIV. Globally, in 2018, an estimated 10 million people developed TB, and there were nearly 1.5 million deaths, including 251,000 deaths among people living with HIV. TB continues to be the most common opportunistic infection and accounts for nearly 1/3 of deaths among people living with HIV. However, even in people living with HIV, TB is preventable. Antiretroviral therapy has been shown to reduce TB incidence. However, ART alone is insufficient to prevent TB. A meta-analysis conducted by Suthar and colleagues and published in PLOS Medicine synthesized findings from 11 studies that compared TB incidence by ART status in adults living with HIV based on 4 categories of CD4 count: all baseline CD4 counts, CD4 less than 200, between 200 and 350, and greater than 350. As shown in this figure, ART was strongly associated with reduction in TB incidence across all CD4 count strata, with about a 65% reduction in TB incidence overall. However, despite global scale-up of antiretroviral therapy, people living with HIV are 19 times more likely to develop TB than those without HIV. TB preventive treatment has an additive protective benefit in people living with HIV receiving ART. Ranganka and colleagues conducted a randomized placebo-controlled trial in South Africa in which they assessed the effect of 12 months of daily isoniazid on the risk of TB in adults living with HIV who were on ART. This figure depicts the cumulative probability of tuberculosis among participants receiving IPT in red and placebo in blue. As you can see, they found that IPT independently reduced the incidence of TB in people living with HIV on ART by 37%. TPT has also been shown to have a durable survival benefit in people living with HIV, independent of ART. The Temprano trial was a 2-by-2 factorial trial that assessed the benefits of early ART and 6 months of IPT in adults living with HIV in Côte d'Ivoire. In this analysis, 2,056 participants with a median baseline CD4 count of 477 were followed for a median of 4.9 years. This figure depicts the cumulative probability of death among participants receiving IPT in red and not receiving IPT in blue. IPT led to a 37% reduction in mortality. The efficacy of IPT was independent of ART initiation and CD4 count. Notably, the benefits of 6 months of IPT were sustained for up to 6 years of follow-up. TPT has also been shown to benefit people living with HIV with advanced disease. In the reality trial, HIV-positive adults and children with a CD4 count less than 100 starting ART were randomized to receive enhanced prophylaxis, including IPT or cotrimoxazole alone, and were followed for 48 weeks. Participants who received enhanced prophylaxis had a 33% reduction in the risk of TB and a 24% reduction in the risk of death. More recently, newer TPT regimens, including a 3-month course of weekly rifapentine plus isoniazid and a 1-month course of daily rifapentine plus isoniazid, have been shown to be non-inferior to a 6 or 9-month course of IPT, with less toxicity and better completion rates. This figure from the brief TB study demonstrates the non-inferiority of 1 month of daily rifapentine plus isoniazid compared to 9 months of daily isoniazid for the combined outcome of TB or death from TB or an unknown cause. In summary, clinical trial data demonstrate that TB preventive treatment saves lives in people living with HIV, with early disease, as well as in those with advanced disease. 6 months of isoniazid preventive therapy, the most widely used TPT regimen worldwide, has a durable survival benefit that is independent of ART, even in high TB burden settings. Newer short course regimens are potential game changers in efforts to improve coverage and completion of TPT. In this satellite, we will hear about updated guidelines and programmatic innovations aimed at bringing this essential component of HIV care to scale to ensure that people living with HIV are no longer dying from TB. Thank you for your attention.
Good morning, good afternoon, good evening, wherever you are today. I'm Dr. Vindi Singh from WHO Geneva, from the HIV, Hepatitis, and STIs program, and I am speaking to you about the WHO guidelines on TB preventive treatment for people living with HIV. Tuberculosis is the top infectious killer in the world and leading killer of people with HIV, as we've just heard from Dr. Howard. causing a third of global AIDS deaths. And TB preventive treatment has been proven to reduce TB deaths among PLHIV. However, the uptake of TPT among PLHIV is still limited. Only 49% of new enrollees in HIV care initiated TPT in 2018 of the countries that reported. WHO has released its new TPT guidelines in its modular format in 2020, as well as the operational handbook linked to these guidelines. These were led by Dr. Dennis Falzon and Avinash Kanchar from the Global TB Program. What is new in these guidelines? New regimen options, 1 month of daily isoniazid and rifapentine and 4 months of daily rifampicin. A review of the safety of INH in pregnant women living with HIV. Updates based on recent evidence regarding DDIs and PK data, including concurrent use of rifapentine with dolutegravir, pediatric dosing and formulations, weight banding. Updates to implementation considerations, algorithms for testing and treatment, and applicability of these recommendations in different settings. How do we rule out active TB among PLHIV for TPT initiation? We recommend using a clinical algorithm. And in adults and adolescents, we recommend those without current cough, fever, weight loss, or night sweats be offered TPT. Infants and children less than 10 years of age, those without poor weight gain, fever, or current cough, or history of contact with a person with TB. And in infants under 12 months, those without the above symptoms, as well as contact with a person with TB, may be offered TPT. Chest radiography may be used to rule out TB, but is not required to initiate TPT among PLHIV. And LTBI testing by TST or IGRA is also not required. This is a summary of the expanded regimen options that are currently recommended in our guidelines. 6 months or 9 months of daily isoniazid or 6H, 3 months regimen of weekly rifapentine with INH or 3HP, daily rifampicin and INH for 3 months or 3RH, and as we've already mentioned, 1HP and 4R. There is a 36-month of daily isoniazid recommendation for specific high TB transmission settings, as well as the fixed dose combination of INH, B6, and cotrimoxazole. For children, while there is a pediatric FDC of the 3RH regimen, children with HIV are recommended to initiate 6 months of isoniazid because of drug-drug interactions between rifamycins and various ARVs that children may be on. However, if children are on efavirenz-based regimens, 3RH, 3HP, or 1HP could be options. The dosages for different regimens and weight band dosing for these children are included in our guidelines. Regarding the safety of INH in pregnant women living with HIV, pregnant women with HIV are at higher risk of TB during pregnancy and postpartum, with serious consequences for the mother and infant. And a recent RCT had indicated that INH during pregnancy was associated with 1.6-fold increase in unfavorable outcomes of pregnancy compared with postpartum initiation. So WHO conducted a systematic review of the literature, which included 2 observational studies that did not reproduce this association. Thus, the guideline development group concluded that systematic deferral of IPT to postpartum would deprive women from its protective effect at a point when they were more vulnerable to TB. And just a side note, rifapentine is currently not recommended in pregnancy as more safety data is needed. In April 2020, WHO also released its consolidated strategic information guidelines with updated TB HIV indicators, including TPT initiation and completion. The TPT initiation indicator broadened the denominator to all eligible PLHIV on ART, and the TPT completion indicator has been newly included in this top 40. Additional HIV program considerations are described in various other guidelines by WHO, including the co-administration of 3-HP and dolutegravir, being well tolerated, no dose adjustment needed, TPT being offered as part of routine HIV care, including in advanced HIV disease package of care, as well as differentiated service delivery models of HIV care. As we mentioned, there is insufficient uptake of TPT globally, and the challenges are well known, including reluctance of program managers, healthcare providers, even patients, concerns about toxicities, resistance. As well, there are operational barriers. And WHO has sought to address these concerns with various reviews of toxicities and resistance, and also notes that the newer, shorter regimens offer an option as they are better tolerated. Regarding the operational barriers, much more needs to be done to improve the programmatic implementation of TPT, strengthen M&E systems, improve coordination, and routinely offer TPT, address some of the supply chain challenges, et cetera. So in conclusion, TB preventive treatment is key to reducing TB deaths among PLHIV. We now have WHO guidance that offers a number of shorter regimen options, as well as operational guidance to address some of the challenges in implementation. We have expanded TPT indicators in the new SI guidelines. And as mentioned, the ongoing implementation challenges remain with suboptimal integration of TB HIV services, reluctance, and weak monitoring systems. These need to be addressed, and we need to collaborate across TB and HIV programs to scale up TPT and ensure provision in routine HIV care, and maintain TB HIV services, including TB preventive treatment during this COVID pandemic. I thank you all, and thank particularly Dennis Falzon, Avinash Kanchar, Annabelle Badley, Sabine Verkuil, Dave Laurence, and Meg Doherty for their support in these slides. Thank you.
Today I'll be presenting on adapting PEPFAR TB preventative therapy guidance in response to COVID-19. In the midst of the COVID-19 pandemic, which recently accounted for more than 10.4 million cases worldwide and over 500,000 deaths, our main focus is on supporting continuity of care, diagnosis, and treatment for HIV and TB. TB continues to account for 1.5 million deaths each year, and HIV accounted for nearly 800,000 deaths in 2018. But more than 250,000 of those were related to HIV. We know from past epidemics and outbreaks, as well as modeling data from Stop TB, USAID, and other partners, that shifts in public health and healthcare resources, as well as fear, stigma, and declines in patients seeking care, can drastically increase the morbidity and mortality from HIV, TB, and other diseases in the setting of COVID-19. In 2018, at the UN General Assembly High-Level Meeting for TB, PEPFAR set ambitious targets to treat all PLHIV with TB preventative therapy by the end of FY 2021. PEPFAR countries were beginning to scale TPT more widely with increasingly ambitious targets, as you see here, with an increasing number of targets and increased achievement of TB preventative therapy completion rates across PEPFAR. Since 2018, more than 3.5 million PLHIV have completed TPT. Many country programs have reported declines in case finding and patients at healthcare facilities. TB programs and staff at the national, clinical, and community level have been diverted to COVID-19 response. TB diagnoses have decreased. TB preventative therapy scale-up has been significantly impacted. Multiple countries are at high risk of INH stockouts and limited availability to distribute multi-month dispensing. And there have been delays in 3HP shipments. The PEPFAR COVID guidance has focused on expansion of multi-month dispensing of ARVs, as well as TB and TPT for all, including children. TPT remains a core HIV service, and the guidance encourages that ARV and TB visits and medication dispensing be aligned, and that we should consider that adverse event monitoring can be done remotely using phone, SMS, or other electronic means, such as WhatsApp, while maintaining confidentiality. This is a quick roundup of multi-month dispensing policies for TB, HIV, and TPT for PLHIV and PEPFAR countries. We don't have information for all countries, and some countries are at various levels of implementing these policies. But as of the end of June, 13 countries have implemented multi-month dispensing policies for TB preventative therapy, and 11 countries have implemented these policies for PLHIV with TB. Decentralized drug distribution can take place in diverse settings, and it seems that there is no shortage of creativity among field staff and implementing partners in finding new and innovative ways to ensure they reach patients. Distribution sites include community and private pharmacies, pop-up pharmacies, automated lockers, schools, faith-based organizations, KP sites, and some are delivering directly to people's homes. And lastly, we need to discuss the impacts of COVID-19 on the TB/HIV supply chain, because this has had profound impact across PEPFAR programs. All HIV commodities have experienced between 4 to 6 week delays, and TPT orders are arriving with 2.5 week delays, but with a broader range. 3HP shipments have been significantly delayed due to reduced capacity for manufacturing by Sanofi at their plant in Italy because of movement restrictions, and they recently paused release of new rifapentine shipments due to detection of nitrosamine. McLeod's, it's a generics manufacturer based in India, initially halted manufacturing due to lockdown in India and has had additional delays in submission of validation reports for QA approval. They anticipate resuming manufacturing and shipments later this summer. Thank you very much.
I'm called Dr. Namoenge Proskovia from Uganda Ministry of Health. I'm presenting leveraging differentiated service delivery models to expand TPT and lessons from TPT scale-up in Uganda. As a way of introduction, HIV is the strongest risk factor for developing TB among those with latent or new Mycobacterium tuberculosis infection. And the risk of developing TB is between 20 to 37 times greater in people living with HIV than among those who do not have HIV infection. TB is responsible for more than a quarter of deaths among people living with HIV. However, IPT has been shown to reduce TB transmission among people living with HIV by up to 60%. In Uganda, we are using mainly isoniazid and for TB preventive therapy, and we have these regimens: a 6-month isoniazid, which is the course, which is given daily for 6 months. We also have the QTIB, which is a combination of isoniazid, septrin, and B6, also given for 3 months. As a country, we intend to introduce 3HP which is going to be weekly isoniazid and rifampicin for 3 months. And this will be given to patients who are 2 years and above. And we shall start giving it out in 2021. The eligibility for TPT is people living with HIV for more than 1 year of age with no signs and symptoms of TB, HIV positive children who are less than 5 years with a history of TB contact who have no signs and symptoms of active TB disease, irrespective of the previous TPT status. TPT integration into DSD in Uganda, this is what we have done. We've developed guidelines for provision of TPT in DSD models. And here, the guidelines indicate that TB treatment preventive therapy should be integrated in all our differentiated service delivery approaches. Uganda has 5 differentiated service delivery approaches that include the facility-based models, which is the facility-based individual management and facility-based groups. Then we also have the fast-track drug refills. Then we have the community models, which include client-led at refills or delivery drugs, which is commonly abbreviated as the CLADs. Then we also have what we abbreviate as the CDDP, which is the community drug distribution points. TPT is initiated by a clinician regardless of the DSD approach. So if a PLHIV is to be given or initiated INH, irrespective of which approach they are on, it has to be at the facility. Then during the counseling at the facility, side effects of INH are emphasized, and then the PLHIVs are told to return when they face side effects so that they are assessed to make sure that they don't experience severe side effects. TPT and AT refills are aligned, and in this case, for those who are newly beginning their ART, we provide a 1-month refill for both ART and TPT. And those who are already been on ART, we provide, depending on the approach. For the more intense, the facility-based individual management and facility-based groups, here we give them monthly AT and the TPT refills, whereas for the community approaches, which are less intense, we give them month refills, which go up to about 3 months. And these include the fast track drug refills, community drug distribution points, and the community client-led at drug refills. Clinical monitoring for recipients of care on TB preventive therapy is done at every clinical encounter, regardless of the DSD approach. We have developed standard operating procedures on providing IPT in DSD models, and we have also trained community model leaders to screen for TB and report status to the facility at every drug pickup. This is to ensure that while PLHIVs are in the community models, they don't develop TB without being noticed. During the follow-up, this is what is done for the clients in the different models. For the facility-based individual management models, the health worker usually excludes TB and contraindications as well as side effects. They usually measure and reinforce adherence to both ART and TB and TPT. They do pharmacy, INH, and vitamin B6 refills, as well as recording in the IPT register and the AT card. This is done on a monthly basis. The facility-based groups, still the health worker excludes TB and side effects and contraindications, and also measures and reinforces adherence. They do group INH and vitamin B6 refills. This can be given on 1 or 3 monthly basis, depending on the constitution of the group. 1 monthly if they are new members who are still unstable, and 3 monthly if they are stable clients in that group. Fast track drug refills, still here the health worker excludes TB, does the pharmacy refill for INH and B6, as well as recording in the registers and at cards. And this is done on a monthly basis. So community drug distribution points are led by healthcare workers. Here the healthcare worker carries the IPT register to the community drug distribution point. And usually this is at an agreed point by the group out there in the community. And during that drug distribution, the health worker does the screening for TB and side effects, and then provides the group with INH and B6, as well as recording and updating the IPT register, and provides and reviews the 6-month IPT outcomes, as well as recording them in the register. This is usually done on a 3-monthly basis. Community client-led at delivery is usually led by the PLHIVs themselves. So in each of these, there is a group leader who excludes TB signs and symptoms and side effects, and also measures and reinforces adherence, does group INH and B6 refills, and records on the CLAD monitoring forms, and health worker uses this monitoring form to update the IPT register and the AT card. This is done usually on a 3-monthly basis. This is to show us where we have come from as a country in terms of scaling up IPT. And our scale-up effort started in October 2018 and are continuing hopefully until December 2020, when we expect to achieve 90% of all our PLHIVs to have taken at least one course of INH. And here I mainly want to show you that during the period July to September 2019, we did what we called the 100-day IPT scale-up. And during this time, we are cognizant of the fact that a number of PLHIVs were already in the differentiated service delivery approaches, and therefore we tried to make sure that we align IPT refills together with the ART refills depending on the model, so that the PLHIVs who are already in the communities would not miss out on the IPT scale-up. This shows us the weekly trends of IPT enrollments among the different age groups of PLHIVs in the country. And we decided to disaggregate this age-specific chart to make sure that the children are not left behind, because we realized in our data previously that it was the children who are not being enrolled on IPT. Therefore, we started specifically looking out for children. And you can see that week 1 of 2020 is about January. That's when we started monitoring children. And this shows us how we have performed over time to about end of March. This is the data that we collected from a survey that we did out there, because DSD data is not routinely collected in our national HMIS database. So in this survey, we found that we had a total of 725,000 PLHIVs on ART who were in the different DSD approaches. And from this, we found that 14% were on TPT, and this ranged from 8% who were on CDDP approach to 17% who were in the FBIM approach. So from this data, you see that there is an effort to have at least considerable number of PLHIVs on IPT in the different approaches of DSD. What are the lessons we have learned? We've learned that TPT integration into DSD improves uptake and completion of TPT because of the following reasons that we captured during the survey. This is there is a reduced stigma because of the groups. These people share information and concerns that they might have so that they are addressed. They practice positive living practices, and also the DSD approaches improve access to drugs, which improves adherence. We've also learned that TB integration into DSD supports community TB surveillance among group members, as it is usually done in what we call the CARG. Our next steps as a country is we want to conduct another scale-up campaign as a country, which we call the mop-up phase, which will enable us to reach at least 90% of all our PLHIVs. Then we want to assess the impact of COVID on ART and TPT in the service delivery, on TPT service delivery. We also want to conduct a sequin-funded study to understand factors associated with IPT completion among recipients of care on ART and IPT aligned to multi-month refills by DSD models. I thank you for listening.
I'm Clarissa Gwanzora with the Ministry of Health and Childcare in Zimbabwe. I'm going to make this presentation today on behalf of the study team, one of the studies that we did on the provision of TB preventive therapy to people living with HIV in CARG. This is a feasibility and acceptability study in Zimbabwe. This is the outline of my presentation. I'm going to briefly go through the background, the methods, results, and then finally the conclusion. Just a bit of the country context. Zimbabwe remains one of the top 8 countries in Africa on the world's top 30 list of countries that are heavily burdened with TB, HIV, and MDR-TB. The Zimfia study of 2016 showed that our HIV prevalence is 14.6%, with a co-infectivity rate of 62% from the Global TB report of 2019. The background to this study was seen when we did our analysis for the January to June TPT data 2019, where we noted that only 8% of our people living with HIV were initiated on TPT. The data for December 2018 showed that we only had completion rates of 77%. What is known is that differentiated service delivery models, such as community outreach groups, may provide an opportunity to expand TPT coverage, enhance TPT and also enhance TPT completion. However, the feasibility and acceptability of this strategy is largely unknown. Thus, ICAP at Columbia University partnered with the Ministry of Health Zimbabwe and also other stakeholders to conduct a rapid assessment of the feasibility and acceptability of integrating TPT in CARG. The main objective here was to also provide timely and practical and policy-relevant findings that would inform the scale-up of TPT services in Zimbabwe. In Zimbabwe, data were collected between March and September 2019. We employed 4 different ways of, different methods of data collection. We did 25 key informant interviews with central level informants, 20 key interviews with community outreach leaders. We also had 16 focus group discussions with a total of 136 community outreach group members. And we also observed 8 CARGs with a total of 64 CARG members. Qualitative data was transcribed and translated from English to Shona from audio recordings, and analysis was done using deduce software packages. Quantitative data was analyzed using Stata. So moving on to our results, first we explored the overall acceptability of providing TPT in CARGs. This was one of the closed-ended questions in our key informant interviews of central informants and CARG leaders. And as you can see, the majority of both groups supported the idea. We moved on to assessing perceived advantages of the provision of TPT via CARGs. And the advantages that were seen were mainly related to the advantages that are already being seen with community outreach groups, such as already utilizing the system that's in place, psychosocial support, promoting adherence, and saving time. A central level key informant say that the same advantages found in ART distribution through CARGs are a replica of INH being distributed through CARGs. Monitoring of drug toxicity, helping in adherence, in their small group communities to ensure that members take their INH over the entire course. A community outreach reform group leader said the advantages are for healthcare workers. They don't get extremely busy because most of the times when we come to collect our medication, we normally arrive and it's already packed, so you won't disturb others. And one of the members interviewed said, I think it is good because when a person is on treatment and they experience those side effects that we mentioned, one person may decide to default, but when we are as a group, we will encourage each other to endure. We also looked at perceived disadvantages, and these included potential challenges with coordination, medical stockouts, and unknown impact on TPT adherence and safety. One central level informant said, I think it will just create a logistics nightmare in terms of being able to account for medicine right down at that level, and then that is where the main issues are. We then went on to test some specific scenarios, starting with approaches to TPT demand generation and initiation. So we had two approaches, and in the first approach, CAG members who have not yet been initiated on TPT would be encouraged to ask for it at their next scheduled clinic visit. And in approach two, CAG members who have not yet been initiated on TPT would be encouraged to return to the clinic right away to request for TPT. Central level informants preferred approach one, slightly more than CAG leaders who preferred the second approach. We also explored opinions about 3 different approaches to TPT service delivery in CAGs. So in model 1, a CAG member who is initiated on TPT would have to leave the group and is seen at the clinic monthly for the duration of TPT. So they would have to come back to the facility every month and receive their clinical examination whilst taking TPT in their ART, and then they would return to the group after TPT, after their TPT course has been completed. The model 2 is a hybrid where once a CAG member has been initiated on TPT, they make monthly visits to the clinic for the first 3 months. Then if they're doing well, they receive 3 months of TPT and 3 months of ART, and then return to the CAG group. And then the last and final model that we looked at was having TPT given entirely within the CAG. So TPT is initiated at the clinic but administered entirely within the community outreach group. The member would not be seen at the clinic following initiation, but would receive 3 months of TPT and ART at a time and be motivated by CAG leaders. And generally, model 3 was preferred by all the groups that we interviewed, even though concerns were noted about safety and safety monitoring. So this is just a graphic presentation of those responses on the preference of the third model, but it's comparing all the 3 models. So what you see on the x-axis is the 3 bars for each model. The first 3 bars show responses on the first model in which people receiving TPT leave the CAG group and return to the clinic monthly. So if they are on INH, they return every month for 6 months. If they are on 3HP, they return every month for 3 months. The first bar shows responses from central level informants, the second bar from the CAG leaders, and the third from CAG members. And as you can see, only 30% of people in each group agree or strongly agree with this model, the first one that we highlighted. And CAG members were the ones who were most strongly opposed to this model. And then now looking at model 2, where there are monthly visits for 3 months and then follow-up continuing within the community outreach groups. From this slide, you can see that this was more popular with central level informants and CAG leaders, but still CAG members were still opposed to this model. Then these 3 bars show the third model, where TPT is entirely given within the community at risk group. And the green bars clearly show that this was more, popular. It was popular with all the 3 groups. And now you can see the change in the buy-in from the CAG members. We then went on to look at the reasons why participants agreed or disagreed with this model. So some of the reasons that were given for agreeing to model number 3 included the reduction in workload for healthcare workers, the reduction in clinic visits, and also the belief that monitoring for adverse events is possible and is feasible within community at-risk groups. Some of the reasons that were given for disagreeing with model number 3 included the issue about increasing responsibility that is placed on community at-risk leaders and concerns about safety in the absence of clinicians doing the monitoring for side effects. So one central level informant said the patient needs to be assessed by a trained clinician so that they can be able to carry on with their treatment without any problem, and they can also be able to encourage others even in the future who may decide to start TPT. No, I think that approach, I would not recommend it. So they're just supporting their point why they would disagree with the implementation of model number 3. Our results from CAG observations, these observations, we noted that the majority of the CAG leaders, they had a median of 2 years being in that position supporting community at-risk groups. 16 out of 20 reported that they'd received some form of formal training for their roles as CAG leaders, and 7 of them had also received subsequent training after the initial formal training. And the majority of them, almost all of them noted that there was need for more training. So 8 community at-risk group meetings were observed, and in 7 out of these 8, it was noted that the community at-risk leaders assessed adherence from their members. So they asked how members were taking their AT, and in just above half of the meetings, they also checked if there were any health issues, new health issues which needed to be attended to. However, it was worrisome to note that only in 2 of the 8 meetings where participants or members asked about TB symptoms. So in just 2 of the 8 meetings, TB screening was conducted, which is one of the responsibilities that has been given to community at-risk groups. So as part of our discussion and conclusion, what we noted was that all respondents were open to provision of TPT in community at-risk groups, and all preferred at least some multi-month dispensing of TPT rather than leaving the community at-risk group and then returning later. From the results, we also noted that additional training and supervision of community at-risk group leaders would be required to implement this approach to support the additional responsibilities that they will be receiving as part of their duties as community at-risk groups. And the shift to 3HP will facilitate expanded TPT coverage with minimal CAG disruption. So the groups will be able to continue functioning regardless of adding TPT to that. I'd like to acknowledge all the stakeholders who participated, who made this study possible, and also the co-authors who are listed here. Thank you very much.
Good afternoon, good morning, good evening, everyone around the world. My name is Lynette Mabote, and I'm the co-moderator for this session with Dr. van der Biel. Thank you so much for joining us so far. We've heard 5 very powerful presentations that have looked at what the policy landscape is for TB preventive therapy, that have then taken us through various country experiences to actually help us or distill where we are in terms of implementation. Dr. Singh mentioned earlier that, we seem to be struggling where HIV and TB integration is concerned. But I think from what we've heard from our other speakers, it seems as though there's a lot more momentum that we're seeing. The first question that we have is actually for Dr. Singh. And we wanted to ask the question about what countries can actually do right now to scale up the implementation of TPT guidelines. And we had a second question actually from a gentleman by the name of Lionel Leberons. And he was asking the question around, are tools available for clinicians to use for symptom screening as well as for TPT? If you could please just answer those questions for us, Dr. Singh, thank you.
Thank you very much for that great question. I'll maybe just start with the question about the tools, which are available through various mechanisms, but I will direct him to the operational guidance that WHO has developed, and there are various links in that guidance. ICAP Sequin Network has also developed some tools, so there are a number of tools out there. So hopefully that will be helpful. In terms of how to scale up, what countries can do to scale up TPT, well, it's so exciting to hear from Uganda Ministry of Health and Zimbabwe Ministry of Health about what they have been doing and breaking ground with different approaches, with using DSD models, initiating TPT in the community, moving towards the shorter regimens. There is a great momentum right now to scale up TPT. We have funders such as PEPFAR and Global Fund that are keen to support these efforts. We have a global UN targets to reach. We have NTB strategies and UN political declaration targets. There is a lot there's a push towards prevention. This year's TB Union Conference will also be focusing on prevention. So we need to harness this energy and discuss with each other, reach out to countries that have been already implementing, such as Uganda and Zimbabwe, and learn from each other, and also take a look at our guidelines and operational guidance for specific suggestions. There are many partners in country as well as globally that would be glad to assist. So I'll stop there. They're welcome to reach out to me, of course, and we can support as best as possible. Thank you.
Thank you for that. Thank you for that, Doctor. For our two countries, Dr. Namwenge and you, Dr. Gwanzuda, we wanted to know actually about how COVID-19 has actually impacted a lot of your amazing work. You seem to have started really strong, and we just wanted to know whether or not you're still maintaining that momentum of scaling up TPT, or whether or not there have been adverse effects because of COVID-19. Let's start with Dr. Namwenge from Uganda. Okay, Doctor, you can go ahead.
Thank you very much. Thank you very much, Lynette. COVID has impacted on our momentum for IPT scale up because our country was locked down in March. It is still in lockdown, but it was locked down for 3. Currently, we are in a bit of the ease of the lockdowns has really affected the people or patients who had to resign and be going to get acted on, and patients were not able to get medicines. So because of that, many of the PLHIVs who had to get their homes or to the nearest facilities, or some of them who didn't get the information actually just missed out. So COVID in a way has really slowed down our operations because the transport was locked down completely and we were not able to move. So with that, it slowed down our momentum, what we had planned to achieve in a shorter time.
And Dr. Kwanzira, sorry, instead of actually answering that question, we hear, I mean, some amazing things are happening despite some of the challenges we're facing, even with TPT scale up. How far is Zimbabwe in implementing TPT or the new TPT regimens?
Thank you, Lynette. So for us, we adopted the new WHO guidelines for the use of 3HP as our main regimen for TPT, and the plan had been to start implementing this year, and we were going to start with an evaluation, just feasibility of scale up earlier this year. Unfortunately, with the coming of COVID and the COVID response, we had delays in the delivery of 3HP, which is supposed to arrive earlier. So we're delayed in starting the feasibility the feasibility of scale-up study that we had planned to do earlier in Q1. But the medicines are now here and they are now in the facility, so we're going to be starting this quarter to initiate clients on 3HP. And hopefully, when we get the next batch, we'll then be initiating more and more clients and more people living with HIV on 3HP. But we're still continuing with initiating clients using our INH, but we are hoping to move to the 3HP as we go, and as the COVID response gets better and ships are able to move, and we can have drugs in country faster and have more drugs available for patients.
Thank you very much for that, Doctor. Dr. Al-Samira, I wanted to actually come back to you and just ask you about the amazing work that PEPFAR has done, actually, number one, in scaling up TPT within, the global guidance. And then secondly, working so hard in the last 3 years to ensure that there was actually, number one, scale up of TPT at country level, where PEPFAR supports, and number two, ensuring integration. I know that you've been pushing DSD. I wanted to ask you, especially because we've been hearing questions from audiences, and the questions are around, how are we circumventing issues around the side effects? Are there any adverse effects that people are suffering, especially now that we are pushing an integrative model instead of just having standalone offering of TPT? What can you tell us about that?
Thank you for that question. So the question being about side effects and the monitoring around side effects. So we've been monitoring pretty closely and really looking to our country colleagues to hear about what side effects have been happening. And there have been very, very few reports, thankfully. It's really something that we encourage, kind of active surveillance and active monitoring locally. But we haven't heard any kind of reports of severe toxicities related to either INH or 3HP. I think there was some early reports, and I kind of looked to my Uganda colleagues around possible hepatotoxicities when they were doing this 100-day scale up. But I think those were fairly limited and resolved. But I just sort of want to take this opportunity to, as PEPFAR, we have worked really hard to set the stage and the targets and the ambition, but it's the work that's done locally and by countries, and the ambition that was set by Uganda and the commitments that countries like Zimbabwe and Kenya and Tanzania are making and really scaling up TPT and finding ways to ensure that patients are reached through these diverse models, through DSD, through multi-month dispensing, through COVID-19, and ensuring that patients get that treatment because they recognize it's life-saving. That work is really done by our colleagues in country. So I just really want to take this opportunity to thank them.
Thank you very much for that. Just to also mention the fact that we should also thank donors such as UnitAid, who are currently funding the Impact for TB project, which is doing amazing work in some countries in scaling up TPT, especially the newer TPT regimens such as 3HP. And the work of communities that they've done. I mean, Dr. Gwanzura spoke about ZNAP Plus, Zimbabwe Network for People Living with HIV. They've been doing amazing work, I think, on the ground to try and scale up the voice, ensure policy preparedness, and to get us where we need to go with TPT. Thank you very much for answering those questions. And I will now hand over to my co-moderator, Dr. Van der Biel.
Okay, thank you very much, Lynette. I think we have reached the hour, so we are going to close the session here. Thank you very much to everyone for participating in the session. Thanks to Sequin for convening the satellite, and also thank you to the Bill and Melinda Gates Foundation for their support. So thank you to everybody, and have a very nice evening or remaining of the day. Thank you.